Good evening, everyone. Good evening, Hyderabad Nephrology Forum. I'm Dr. Praneeth Ram. I'm the consultant nephrologist from Yashoda Hospital, Hyderabad. I'm actually, for a nephrologist point of view, thrombotic might be frustrating diagnosis. It involves a lot of workup, and often we end up with no diagnosis sometimes in some patients. So I will be sharing a few of my cases, and I will be discussing some of the clinical clues which I found useful while managing this group of patients. So these are the learning objectives of the current talk. First, I will be speaking about pathophysiology of TMA, and next I will be focusing on the approach to the TMA, and briefly I will be discussing few features regarding each entity, and at the end I will be discussing my cases, and I will also focus more on the analysis of these patients. So to start with, similar to the other autoimmune etiology, it involves two hits, that is trigger and predisposing condition. So while managing this group of patients, it is always important to look for the trigger, what has caused this group, this disease, so that we can predict the future relapses in this group of patients. And in almost all the conditions, it involves the damage to the endothelium, resulting in the exposure of the subendothelial matrix, thus causing the thus promoting the thrombosis. Further further resulting in the organ ischemia. Also, it results in the mechanical damage to the RBCs, thus resulting in the intravascular hemolysis. So, yeah. So if you look at the complements, they actually sit in a tight position, tight and very crucial position, linking both complement pathway, correlation pathway, and the inflammatory pathway. So it is no wonder that in this group of disorders, the complements were primarily involved in the various pathogenesis. And as shown here, primarily the TMA is divided into primary and secondary causes. The primary causes involve definite pathogenesis. So, and they differ from the secondary causes by not the secondary causes don't have exact etiology, exact pathophysiology, and often they have the underlying primary condition as a predisposing factor. If you closely observe this diagram, there are definite lines dividing these both primary and secondary causes, but these lines are not definite, suggesting that there is overlap between these conditions too. In the primary category, there are three entities, that is diarrheal associated HUS, that is sugar toxin associated disease, and second entity is thrombotic thrombocytic purpura because of ADAMTS 1,3 deficiency, and the third category is the third entity is the atypical HS because of the complement dysregulation. And in secondary conditions, there are many diseases related to the pregnancy, drug-induced TMA, transplantation, autoimmune conditions, infectious conditions, malignant hypertension, and other congenital conditions. In one of the largest series published in literature, they found that the French group, the French cohort, they say that the secondary causes outnumber the primary causes. And among the secondary causes, it is roughly around 60% of patients has multiple causes, explain the cause for the TMA. And the outcomes in this group varied according to the underlying primary condition. So coming to the approach, and this is the most important slide, which I will be discussing further in the further presentations. Further slides. First and foremost, we need to label a patient as a TMA if they have these two conditions, that is presence of thrombocytopenia and microangiopathy hemolytic anemia. MAHA is defined by the low platelet count, low hemoglobin, red cell fragments in the peripheral smear, increased elevated reticulocyte count, elevated LDH, haptoglobin, elevated bilirubin, and Coombs test negativity and normal coagulation profile. Coombs test can be positive in two conditions, that is autoimmune diseases and in conditions associated with the Streptococcus pneumonia. So once these two conditions are met, we have to look for the ADAMTS 1,3 activity and Shiga toxin in the stool. ADAMTS 1,3 level is not available often in various settings, especially sometimes even in tertiary care centers also this test may not be available. So I suggest to look for the bedside scores, that is plasmin score or French TMA score. So if that is positive and in appropriate clinical setting, we can order the RNTS 1,3 activity, and if it is positive, then we can label the patient as TTP. Coming to the other entity, other arm, that is if Shiga toxin is positive, we can label them as Aztec HUS. If these two are negative, then we have to look for the secondary cause of TMA, and if negative, then HUS. What is striking here is the overlap. Means there is no definite clear-cut margin differentiating between the atypical HUS and secondary TMA. So Aztec HUS, this is actually more common in the children. It occurs either in the epidemic setting or the sporadic setting. Recent studies suggest that the sporadic incidence is more common than the epidemic setting. It always precedes with the diarrhea. Usually, the diarrhea initially is non-bloody and followed by bloody diarrhea in roughly 80% of patients. By day 7, most of the patients recover. Roughly in 10% of patients, they will have the manifestation of HUS. So again, once the HUS is manifested, most of the patients recover. Roughly around 70% patients recover. But what is worrying is like nearly 30% of patients will have that one should evaluate for the stool culture or stool PCR, especially in the diarrheal phase. Once we miss this phase, then it is highly likely that we may not get the positivity in the further period. So, in the epidemic setting, if the patients, if the children present with non-bloody diarrhea, it is always important to look and for the Shiga toxin analysis by performing appropriate tests. Next disease is TTP. It is due to the deficiency of ADAMTS 1,3 protein. It is a metalloproteinase protein. It mainly splits the von Willebrand factor. Von Willebrand factor is released by the endothelium. It is usually a large multimer. So, in the absence of ADAMTS 1,3 activity or decreased deficiency of this protein, the multimers are seen circulating in the blood. And this results in the aggregation of the platelets, thus resulting in the TTP. TTP classically has pentad, that is thrombocytopenia, MAHA, fever, neurological involvement, and renal involvement. But this is seen in only 40% of patients. And we can actually predict TTP in the bedside by looking at the plasmic score of French TTP score. If in the appropriate setting, if these scores are satisfying, means then there is high likelihood that the patient has TTP. TTP is very unlikely if the serum creatinine is high or the platelet count is very is more than 30,000. Atypical HUS, this is again more common in the children, adolescents, and young adults. This is usually due to the complement dysregulation in the alternate pathway, thus resulting in the increased expression of the MAC on the endothelium, resulting in the damage to the endothelium. So it is usually due to the disequilibrium between the regulators and the promoters. The regulators protein are CFH, CFI, and MCP and thrombomodulin. Usually, these molecules are present both in membranous and fluid phase. Atypical HUS occurs in the abnormalities related to the membranous phase of these regulators. And it can be because of the gain of function mutations of the promoter proteins. In one of the largest series available in the Brazil patients, they found that the underlying complement gene abnormalities are seen in 50% of patients. But this test is performed in only 50%. And this number varies from the country to countries. So to standardize the methods, the American genomic guidelines have published recently regarding the number of genes to be analyzed and the method to be analyzed. So uh, the most common mutations are related to the CFH molecules, followed by the MCP and CFI. Uh, and as compared to the regulator protein mutations, the the gain of function mutation are relatively less. Uh, Roughly in 20%, 12% of patients, we have the combined mutations. Coming to the first case, he's an 8-year-old male presented with vomiting, abdominal pain for 10 days, and he had history of fever for 1 day. And his past history is significant for only febrile seizures that occurred at around the age of 2 years. At presentation, he is severely anemic and the platelet count was normal. On examination also, he has severe pallor and periorbital puffiness. These are his labs. He was having severe anemia, but platelet count was normal. His peripheral smear showed 4% schistocytes. Retic count was high. He had creatinine of 4.8, which is very high for his age, and his urine analysis showed proteinuria, and protein creatinine ratio was around 4 grams. He was also his LDH is very high. He was found to be having COVID IgG positive. And subsequently, we got C3, C4 levels, which were very like see. Actually, I could not see this. Okay. Uh, C3 was low and C4 was normal. Subsequently, his dengue antigen was found to be positive. He is actually having criteria satisfying the MAHA and also AKA. So, in the setting of low C3 levels, we can actually label him as atypical HUS. I was called for doing biopsy for this patient, and I did biopsy. This is the this is the light microscopy of the patient. As shown here, there are 4 glomeruli, 1, 2, 3, and 4. And almost in the higher magnification, we are able to see two patterns, two different colors. This is deeply red and this is slightly hue. This deeply red thing is nothing but the capillary filled with RBCs. This is this slightly pinkish color is because of the thrombin. As shown here, the glomerulus is this is empty stain. The glomerulus is actually totally filled with RBCs. This is again the ischemic glomerulus. We can see the feeding arteriole getting obstructed with the thrombus, thus resulting in the ischemia of the glomerulus and shrinkage of the apparatus. So we gave him plasmapheresis. We did 7 sessions. He was febrile for 5 days, which was due to the dengue. And once the fever has subsided, we started him on steroids and MMF. Subsequently, his LDH also fell down and retic count also improved. He was followed up on OPD basis, and currently he's doing well. His RFTs and proteinuria has disappeared. So the trigger in this patient is the probably dengue. And we also worked up for the complement, and his anti-CFH antibody was strongly positive. Also, his HUS panel was positive for chromosome 1G, which is nothing but CFH R protein. Secondary TMA, it is actually an umbrella term for and this, as we discussed previously, it doesn't have exact pathophysiology to explain the causes. So in drug-induced TMA, there are two phenomena which are in literature. One is immune-mediated. It is because of the formation of antibody. The onset of disease is usually sudden and very severe, and this group has to be managed with immunosuppression and the plasmapheresis. Coming to the other entity, that is direct drug toxicity. This is seen in two settings, that is anti-cancer drugs and immunosuppressant drugs. Usually, the onset of disease is delayed because of the cumulative drug toxicity. Uh, Coming to next entity, that is malignant hypertension related TMA. Often atypical HUS also presents with malignant hypertension, and it is very difficult to differentiate the hypertension related TMA and atypical HUS related TMA. So some features like presentation in the male, elderly, and the history of antihypertensive drug usage and recent repeated skipping antihypertensive drugs, and rapid resolution of the TMA features after the controlling hypertension, absence of thrombi on the biopsy, presence of left ventricular hypertrophy, and not requiring dialysis. All these features may possibly suggest essential hypertension more than the atypical HUS. So, in one of the who has more underlying complement gene abnormalities, as suggested in one of the previous analysis, the ATP-HUS has higher incidence of complement gene abnormalities. This group is followed by the malignant hypertension population. This group is also has higher percentage of complement gene abnormalities. So it is important to look for the complement gene abnormalities, and because this group actually benefits with the definite treatment, that is that is eculizumab. Apart from these two groups, other groups like in some of the infectious related TMAs and autoimmune diseases also has underlying complement gene abnormalities. So who should be worked up for the complement genes? All these groups, that is primary atypical HUS, malignant hypertension group, pregnancy related HUS, uh, some patients with STEC HUS, and post-transplant de novo TMA after ruling of the antibody mediated rejection and drug toxicity. All this group has to be worked up for the complement genes. STEC HUS, especially if it is recurrent and the organ failure happened because of after the HUS, this group also needs workup. So roughly around 20 genes were needed to be worked up as per the recent guidelines, and they suggest they have clearly recommended to use NGS or multiplex ligation dependent probe methods. Coming to our case two, he's 27-year-old male. He presented with malignant hypertension and volume overload. His BP was around 190 by 100, and his ABG showed mild metabolic acidosis with creatinine 6.9. And CT just done in emergency also suggested the pulmonary edema. His 2D echo revealed a mild concentric LVH and with moderate LV dysfunction, and he was given diuretic challenge in the ER itself. Then he significantly improved. So he was shifted to ward. These are his lab reports. His CBP didn't reveal any thrombocytopenia, and pepper smear was also normal. His RFT's creatinine was around 6.6. His urine analysis showed proteinuria roughly around 8 grams. His NT-proBNP was very high, but his ultrasound was normal. So we proceeded for renal biopsy after doing dialysis. This was his biopsy. Um This is his biopsy. This is a Masson trichome strain. As shown here, the glomerulus is sclerosed. It has become totally blue. It is totally sclerosed. And in one of the in one of the other slides, we are able to make out the thrombus in the arteriole. And here also we are able to make out the thrombus. So he was labeled as renal limited TMA. Subsequently, his creatinine didn't improve, and he was declared as ESRD, and his dialysis was continued. He underwent left RC AVF. Thrill was good, and he got discharged. Because he had TMA, we sent workup for the autoimmune markers, and the C3, C4 were normal, and autoimmune markers were also negative. At the time of discharge, the APLA workup was awaited. Uh, After 2 days, his thrill was absent in the AV fistula, so he was initiated on heparin on OPD basis, and he underwent repeat fistula creation in the brachiocephalic region, and subsequently his Appler workup came, and it was positive for beta-2 glycoprotein IgM. So our diagnosis, we attend diagnosis in this patient, that is chronic APS nephropathy. And moving to the next case, he is 28-year-old male. He is a known case of chronic relapsing ATP. He was initiated on steroids for quite a long period. Because he didn't respond to the steroids, he was asked to start on romiprostim, which is a protein molecule, thrombopoietin stimulator, which is a protein molecule. He was initiated 4 months before presenting to us. For 2 months after initiating this drug, he developed hypertension and developed renal dysfunction, and ultrasound also showed mild increase in echo texture of the kidney. He was advised to consult nephrologist, but he didn't turn up. He presented to me with fever, weakness, and loose motion for 1 day, and the rest of the examination was normal. His labs showed severe thrombocytopenia with platelet count of 25,000. Creatinine was 3.4, and there was albuminuria on urine analysis. So his peripheral smear showed schistocytes of 2%. Coagulation profile was normal. Proteinuria was around 4 grams. Creatinine was 3.4. And his DCT was positive, 3 plus. And we sent autoimmune markers like serum complement levels, Adam TS13 level, because he had severe thrombocytopenia. We sent this, and we sent APLA, ANA, and ANA profile. So he has MAH, evidence of MAHA, that is thrombocytopenia, schistocytes, mildly raised LDH, and albuminuria. So based on this, we labeled him as TMA, systemic TMA, and we thought of initiating Plex after giving a pulse steroid. What is striking here is the DCT positivity. So we thought that it is an autoimmune phenomenon related TMA. So this was after 2 sessions of Plex, his platelet zoomed to nearly 1 lakh. And we did biopsy, and we thrilled to see this response, and we were very much satisfied with this. And subsequently, his complement also turned out to be low. C3 was low, and C4 was borderline low, like 14 was cut off, and it was 13.4. Adam TS13 level was normal, and rest of the profile was normal. In APLA, we got only ACL at that time. That was negative. So this is his biopsy, HND stain. As you see here, there is almost capillary got filled up with reddish hue. So this is again thrombus, and this is silver stain showing significant arteriolar sclerosis. And here we could make out one of the thrombus in one of the arteriole. This is again Masson tricone stain. We are able to make out the thrombus in the artery. These are the two things. So we were confident that it is autoimmune mediated disease. We thought we should continue the plasmapheresis in this patient. What baffled me was, like, after the third session of plasmapheresis, the platelet count suddenly came down like nosedive. It almost became like 5,000 or 10,000 after day 6 or 7. We are unable to explain this rapid fall. We thought that it is because of complement mediated rather than the antibody mediated. And actually, at this time, we thought that we are missing diagnosis. And I advised the complement workup at this time. Actually, because of miscommunication, it was not sent initially. So we sent after 3 sessions of plasmapheresis. Because of low platelet count, we thought of the patient may bleed further. So we avoided further Plex, and we just gave him FFP. So after FFP, the very next day, patient actually deteriorated. He developed significant hypoxia with requirement of nearly 15 liters of oxygen, and he was shifted to ICU. So this is his CT chest. As shown here, there are bilateral diffuse ganglia opacities. There is peripheral sparing, and and these are my differentials at that time. That is either uh, 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 diffuse alveolar hemorrhage because of the severe thrombocytopenia, or pulmonary edema, or atypical infection. We did COVID PCR at this time. That was negative. So we really thought that we lost the patient. Suddenly, my pathologist came with C40 stain, like without request. She actually did on her own. On her own, she told that it is autoimmune antibody mediated, because on C40, actually, if you see, there is a nice capillary wall uptake, and lumen, we are able to see all the capillaries got uptake, and this is related higher magnification. We are able to locate the lumen, and it is nicely picked up on C40. So at this point of time, we were confident that it was antibody mediated. So our plan was to continue Plex further, but he had severe thrombocytopenia. And on the same day in the evening, we got the beta 2 glycoprotein report, and it was also elevated. So at this point of time, we gave him IVAG, and we gave him high dose IVAG, and subsequently the patient got stabilized, and within a day he was shifted back from the ICU to the room. But what was unexplained in this case was like this fall in the platelets we were unable to explain. So we sat with the family, and we actually came to know that at this point, just before the admission, the patient received a romiplastin. So this rapid rise and fall is because of the sudden stopping of the romiplastin. So we thought of giving the romiplastin at this time, but actually in this case the romiplastin was the probable trigger. So we thought of avoiding it. So we didn't give romiplastin. Instead of that, we replaced it with other thrombopoietin molecule, that is non-protein molecule, that is L-tamboprog, with a dose of 75 mg. Gradually, his platelet count improved further. On day 14, he developed catheter-related bloodstream infection. Once the fever settled, we gave him rituximab at this point. Currently, the patient is doing well. He is being followed on OPE basis. His creatinine is around 2.4 to 3. His platelet count is also near normal, nearly around 1 lakh. This is his complement report. His anti-CFH antibody was negative, and HS panel NGS also didn't reveal any complement genes. So the diagnosis is like APSN, that is APLA-mediated sclerosing nephropathy for this patient. So what is APLA-mediated TMA? It is also like it also occurs with two hit hypothesis. What is clearly what is different in this disease is like there is activation of endothelial cells, monocytes, and platelets. Thus, there will be intense sclerosis of the vessels apart from the prothrombotic state. Usually, it is of two types, that is primary APS, which is relatively uncommon, and secondary APS, which occurs in the underlying in the setting of underlying autoimmune diseases, so, which is relatively more common. The clinical presentation varies from the type of vessel involvement, that is large vessel stenosis or thrombosis, or small vessel involvement manifesting as TMA. If you look at the pathophysiology of APLA related TMA, it is of three types. That is simple formation of thrombosis in the large vessels, that manifesting as a large vessel thrombosis. This group needs treatment with anticoagulation. And there is another group with predominant complement involvement. So this group may probably require eculizumab as a specific therapy. And the third group is the complement independent group. This group usually presents with intense sclerosis of the small vessels. thus resulting in the vasculopathy. This group may benefit from the mTOR inhibitors. So, suppose this group of patients go into end stage and they plan for the transplant. So, using eculizumab in the post-transplant group in this group may be of benefit. Suppose if this group goes in transplant, replacing CNI with mTOR inhibitors may be of benefit. So before this presentation, I asked my pathologist to do C4D stain for the case 1 and 2 also. So she did it, and these are the reports actually. This is the C4D stain of atypical HUS patient. As shown here, there is intense C4D stain, but the staining is seen in morely in the capillary lumen. If you compare this one, there is actually the stain is apparent on the vessel wall. The capillary lumen is normal. So actually what I mean to say is this is a false positive. Because of the trapped plasma within the lumen, this has picked up the stain. So this is false positive. And this is actually true positive. So this suggests that the antibody is the culprit which has resulted in the APSN. So what is the role of C4D? I suggest all the forum members to read this article because it is a though it is a novel concept. Actually, actually looking at the C4D stain in APLA or secondary TMA will give us so much leads. Actually, as per this article, they say that they included heterogeneous group of patients, both native kidney disease and post-transplant patients, and they stained for all the complements like C4D, MBL, C1Q, IgM, and membrane attack complex. And they looked at the pattern of the staining of the C4D. They said that the complement pathway was activated in nearly 90.5% of TMA cases, and nearly 88.1% of TMA cases has C4D deposits. So the staining occurred predominantly in the glomeruli and the arterioles. So this is the summary of this article. If the pattern of staining is predominantly arteriolar, it is probably a complement-mediated HUS. If the pattern of staining is predominantly glomerular, probably then it is it is antibody-mediated disease. So this is a summary of my talk. First and foremost, we have to label TMA if there is thrombocytopenia and evidence of MAHA. If it is there, we have to rule out the secondary causes by doing appropriate screening methods. Because the secondary TMA is more common than the primary TMA, we should look for the secondary causes. If negative, then we have to evaluate the adenylase 1,3 activity. Always this may not be readily available in our setting, so we can actually replace this with TTP scores like plasmin score and French TTP score. If positive, then we should go for this and treat accordingly. If negative, then we have to look for the sugar toxin testing in the stool. If it is negative, then we should actually label the patient as the primary atypical HUS and do the complement workup. So primary atypical HUS is actually a disease of exclusion. We should not jump directly to the primary atypical HUS instantly. Also, it is very important to look for the role of the complement in cases of TMA, because if positive, then we should actually offer the patient the complement inhibitor as early as possible, because it results in the early recovery of the patient. This should be this should be intensively screened, especially in the secondary TMA. If complement positive, we should consider the eculizumab as early as possible. Suppose if it is negative, then we should try treating the primary condition first. If the patient is refractory to the initial treatment, then we should offer them the complement inhibitor. Yeah. These are the various methods how we document the complement mediated TMA. That is genetic methods, antibody or functional assays, biopsy and proteomics. Thank you. Thank you, everyone. Thanks for the patience.
Dr. Pranit, both the cases are excellent. You've done a very good job of explaining the two types of TMEs. I request Saundarajan to give his comments.
Diagnosing and managing a TMA is an academic challenge, right? Many times, I think we have faced that. As people who say, the typical cases are only in textbooks. No, occasionally we are stuck with cases, especially in atypical HUS. Up to 20% of cases of atypical HUS may not have thrombocytopenia. LDH may be normal, and obviously the cyst size may be variable. In such patient, only presentation could be a proteinuria or unexplained anemia or azotemia. And we are totally missed the diagnosis, do a biopsy. Then comes the surprise. There are occasions it has happened like that. And availability of eculizumab has changed the management and our outcome. Earlier, we used to be content only with plasma infusions and exchanges and whatnot, and many of our patients did not do well. I think we could see some survivors only with the, though it is expensive, and the duration of therapy is also controversial. These are all some of the newer things which you could see. I think Pranit Ram has done a wonderful job of explaining, doing things. And that's a very, very nice presentation. I learned so many things from you. Thank you very much for the opportunity. K. Krishnamurthy can take over.
There are two questions here from Abdul Hamid. One is flex with COVID and dengue. Why? And why methylprednisolone 1 gram? Is it a high dose? Two questions to Pranit.
Yes, sir. Flex with COVID and dengue. Yeah. Actually, the patient didn't have the manifestations of COVID. Didn't have the manifestation of COVID. His antibody was positive, but because we thought dengue was a triggering factor in this patient, and he clearly had severe organ dysfunction with severe anemia and drop in platelets subsequently. And actually, if we delay doing plex in this case, he may end up in losing the organ. Yeah, and it is very much clear in the paper smear and also complement analysis that it is the alternate complement pathway which got activated, and because we thought it is an alternate pathway activation with the dengue as a trigger, we proceeded with plasmapheresis in this case, but we didn't suspected COVID as a cause for this. Why methylprednisolone 1 gram high dose? Yeah, again, there are various studies regarding the dose of methylprednisolone. Like if especially pulse methylprednisolone, the usual minimum dose is 250. We can use in some settings because because there is a predominant organ dysfunction. We offered him a higher dose of steroids in this case.
Any comments from the other panelists?
So there is one question in chat box from Suraj VR. He wanted could you elaborate on DGKE?
Yeah, DGKE is a congenital, it actually presents in the very early, less than 6 months. Like usually we won't see in pediatric setting only. We'll see this case. TMA because of DJKE is seen in pediatric patients, especially in less than 1 year. So,
any other question from the other panelists?
And the other important thing is like other treatable condition is cobalamin C deficiency. Okay, so we should also keep that in mind. In cobalamin C deficiency, like usually the patients will have a high MCV, like megalocytic thing. Again, the treatment for that is simple B12 injection. So while treating this group of patients, we should also look at MCV parameters and all. Like if it is very high, then we should evaluate further. Usually it manifests as homocystinuria and also methylmalonic aciduria. So we should do the urine test in that group if MCV is very high.
So there are two more questions from Dr. Manjusha Adla, madam. What's the long-term outcome of such cases, and should C4 be done in all cases of TMA? Any guidelines?
Yeah, C4T, the practice of doing C4T is actually a new phenomenon. It is a new practice. It will tell, like, you should take it, you should not jump to a conclusion that because C4T is positive, it is antibody mediated or complement mediated. You should actually see the pattern of C4T staining and interpret accordingly. If you C4T stain in post-transplant setting is different. C4T stain in post-transplant setting, if it is predominant PTC deposition, then it suggests actually drug antibody-mediated rejection. So in native kidney, if C4T is positive, that too glomerular stain positive, then it may suggest the antibody-mediated disease. If it is arterial uptake, then it will suggest usually the probably like complement mediated disease. So this requires actually further research and further work on it, actually, because it is coincidental in my case actually.
One more question, sir, from Manish Sharma. Immunosuppressive roles in TMA.
Sorry.
Immunosuppressive roles in TMA, sir.
Yeah, if it is antibody-mediated disease, we can actually offer immunosuppression to those group of patients. If it is complement-mediated disease, then we should offer them eculizumab. In atypical HUS, in one condition, there is the role of immunosuppression is presence of anti-CHF antibody positivity. So in any antibody positive disease, we should offer them immunosuppression. So and that's why the differentiation of whether it is antibody mediated disease or complement mediated disease, that is very important while evaluating this group of diseases.
One last question, sir, by Sashi. Plasma exchange at dust is successful in antibody against factor H. Is understanding. In all other cases of complement TMA, we need eculizumab. Please clarify.
Yeah, yes, that's true, sir. Lex is successful in antibody mediated anti-CHF antibody disease. In other cases, that's true, sir. That's a true statement.
Yeah, can I have a comment, please, Dr. Vikram?
Madam, please.
Yeah, so we have quite a good number of case series. So we have tried to look retrospectively. We had a collection of 45 patients, both transplant and non-native kidney disease. So what we have found out is the malignant hypertension was the most common cause in native kidney disease, probably because it's a retrospective study. We didn't have the availability of all these complement the antibodies and then the gene mutation available at that time. So probably we have missed those diagnoses, and we have found out that the prognosis is very bad. Like malignant hypertension, the prognosis was very bad. Almost 90% was graft loss, and almost I think 50% were patient loss. And the next common cause was the autoimmune, and third common cause being the complement, the TMA. In transplantation also, the 50% was the CNI toxicity, and then followed by the ABMR. So progress of all these patients has been very bad, except for the autoimmune TMA, where the plasmapheresis and immunosuppression have worked, and then the outcomes were almost, I think, 60% the patient survival and the kidney survival was achieved.
Agree with you, Dr. Swanlata. We must have missed many of the genetic TMAs when it was not available. Other important point I would like to tell is it does not suffice just to ask for a genetic workup of atypical HUS and let it go, just factor H, I, and MCP and all that. We should know that we should, apart from NGS, we should get it done by multiplex probe ligation assay as well, because some of the times the copy number variations are missed on the other NGS assays. So as the genetic knowledge is increasing, we are able to come to a diagnosis in most cases of TMA, and we should be aware that genetic analysis is available, but we should also be aware what specifically to ask for also. Thank you.
If there are no other questions, I think we are already past the time. We'll close this session. Thank you, Dr. Praneeth. We hand over to the moderators.
More second case, Vikram.
Second case, yeah.
We'll move on to the next presentation. Next presentation is by Dr. Naveen Kumar. It is membranous nephropathy with thrombotic complication. May I now request Dr. Venkatarama sir, Senior Consultant at SCR Hospital and Ajara Hospital, Warangal, and Dr. Sri Bhushan sir, Professor and Head of the Department, names to chair the session. Or to the respected chairpersons. Dr. Venkatarama sir.
Good evening, everybody. At the outset, I thank Hyderabad Nephrology Forum for giving us a chance to participate in this session. Today's second topic is thromboembolic complications in the setting of nephrotic syndrome, which is not an uncommon presentation. Today we have with us Dr. Naveen Kumar, who will present the case and the details. Dr. Naveen.
Yes. Respected seniors and my dear colleagues, good evening, everyone. At outset, I would like to thank everyone.
Share your slides, Naveen.
Yes. At outset, I would like to thank everyone for giving me this opportunity. Today, I am here to present a case of membranous nephropathy with thrombotic complication. I'll go right into the case presentation. This is a 28-year-old male, farmer by occupation, presented to us with complaints of swelling of feet for the past 3 to 4 months. He had one episode of reddish discoloration of urine about 15 days prior to the presentation, and it lasted for 1 day and resolved spontaneously. And for the past 1 day, he had decrease in his urine output and breathlessness. When he presented to us, he was normotensive and he had bilateral pitting pedal edema and left pleural effusion. Other than that, rest of the examination was normal, and his urine was showing 4+ proteinuria with 3 to 4 pus, no RBCs and no CAS. 24-hour urine protein was 5.6 grams and his serum albumin was 1.9 grams. So, and his serum creatinine was normal. At this, and coming to his viral markers, ANA and other things, everything was normal. And because of his breathlessness, we have done a USG-guided pleural fluid aspiration, which turned out to be transudative. And it was negative for malignant cells, and ADA was also normal. So at this point, the diagnosis was pretty straightforward. It was a case of adult onset nephrotic syndrome, and he was planned for kidney biopsy. But to our surprise, his ultrasound has shown perirenal fluid collection around the left kidney. And if you look at the image here, compared to his right kidney, left kidney, there was some increase in the echogenicity also. So this perirenal subcapsular fluid collection is known as wet sign, and it is seen in cases of prolonged severe nephrotic states, in which in such cases it is usually bilateral, and it can also be seen in cases of renal vein thrombosis. This is one case report which has reported perirenal subcapsular fluid collection in a patient with membranous nephropathy. In this case, the patient had to undergo surgical drainage of the fluid, and the last image is the post-surgical image. So in our case, considering the possibility of renal vein thrombosis, we have done a CT angiography, and this CT angiography was showing non-enhancing hyperdense thrombus in the left renal vein, which was extending into the inferior vena cava, but the right renal vein was normal. And there were multiple periureteric venous collaterals seen on the left side, suggestive of chronic venous thrombosis. And there was some suggestion of possibility of pulmonary thromboembolism on the CT angiography, but we haven't pursued further, and CT pulmonary angio was not done because patient was hemodynamically stable, and CT pulmonary angio was not going to change his management strategy. So after CT angiography, we were confused whether to go ahead with biopsy, or is there any alternate way by which we could diagnose. And if you look at the KDIGO guidelines, in the evaluation of glomerular diseases, it is pretty straightforward. All cases of adult onset nephrotic syndrome require a biopsy, except for like in this case, most likely it is the PLA2 or antibody positive membranous nephropathy. That is one possibility which we wanted to rule out before proceeding for biopsy. So if you look at the evidence behind recommending this, this is the ROC curve, which was showing area under the curve of about 96%. That is pretty much comparable with kidney biopsy. So, but the caveat here is that this is applicable only when the patient has no secondary causes of membranous nephropathy and his renal function is normal. That applies to this patient. So if patient turns out to be PLA2 or antibody positive, then we might be able to defer biopsy and start him directly on anticoagulation. So we went ahead and did this PLA2 or antibody, but unfortunately that has turned out to be negative. So again, we are back to this. This is the flow chart showing the treatment algorithm. If patient is PLA2 or antibody negative, then there is no other go but to proceed with biopsy. But here again, the question is whether to biopsy the right kidney or left kidney. That is, left kidney is the one with the renal vein thrombosis. So we could not find any data which has shown that renal vein thrombosis increases the risk, biopsy-related complications risk. So we went ahead and did biopsy on the left kidney itself, and this was the biopsy report. Biopsy was showing 13 glomeruli and 2 arteries. Basically, it was consistent with the diagnosis of membranous nephropathy with the mild diffuse thickening of the basement membrane, and only 5% tubular atrophy was seen. These are the biopsy images. As you can see here, there is diffuse thickening of the basement membrane, and on silver staining, there are faint spikes. This is not very evident here, and there is no significant atrophy on empty stain. And IF was positive for IgG and faintly positive for C3. So the diagnosis here is pretty clear: adult onset nephrotic syndrome with membranous nephropathy, no significant chronicity, and the patient had left renal vein thrombosis and probably pulmonary embolism. So coming to management of this case, his management included 2 things: management of the membranous nephropathy itself and management of renal vein thrombosis. Let's look at each one of them separately. Coming to treatment of membranous nephropathy, the guidelines are pretty clear. All patients should receive optimal supportive care, and immunosuppressive therapy should be recommended only for those at high risk. So, and these are the various treatment options available with regard to immunosuppression. Coming to this patient already had a thrombotic complication and pulmonary embolism, which is life-threatening complication of nephrotic syndrome. So this directly places him in very high risk category. And if you look at the treatment options for very high risk category, it is cyclophosphamide with glucocorticoids, that is modified Ponticelli. But considering his age and risk of gonadal toxicity with cyclophosphamide, we have considered the option of rituximab with or without CNIs also. And if you look at the evidence of comparing rituximab with other treatment modalities, These are the 4 major trials which compared rituximab with other treatment modalities. Gemrutix and Mentor trials have shown results were in favor of rituximab, and Starman trial was in favor of modified Pondicherry regimen, and RA Cyclo trial at the end of 24 months it was in favor of rituximab, but before that it was in favor of again modified Pondicherry. So we have discussed the treatment options with the patient, and the patient has opted for modified Pondicherry regimen. And coming to treatment of renal vein thrombosis, these are the various treatment options available. In cases of asymptomatic cases with unilateral involvement, we can opt for active surveillance along with proteinuria reduction measures and immunosuppression as per the histological diagnosis. And in symptomatic cases, irrespective of whether it is unilateral, bilateral, or even if the patient is having hematuria, early initiation of anticoagulation is indicated, and the anticoagulation of choice is heparin followed by warfarin with a target INR of about 2 to 3. And the other options are thrombectomy and IV stenting, IVC filters. And coming to indications for thrombectomy and local thrombolytic therapy with the mechanical thrombectomy combination, this is indicated in cases of treatment failure while on adequate anticoagulation, or if there are other complications like pulmonary embolism or bilateral renal vein thrombosis, or in cases of AKI, which is attributed to renal vein thrombosis, or in case there is extension of thrombus into the inferior vena cava, or in case of renal transplant or severe persistent flank pain. This patient, although he had mild extension of thrombus into the IVC and pulmonary embolism, he was hemodynamically stable, and the presence of venous collaterals around the ureter indicated that probably it was a chronic renal vein thrombosis to begin with. So the thrombolytic therapy was whether it will be effective or not is doubtful. So we have opted to start the patient on anticoagulation itself. And this is with regard to prognostic factors also. The prognosis in case of renal vein thrombosis depends on, the most important thing is the baseline renal function at onset of renal vein thrombosis. In this patient, it was normal. His creatinine was 0.9, and the status of the contralateral kidney and its vasculature, speed of onset and development of adequate collaterals, which this patient had. So this patient was relatively had good prognostic factors, and hence we have started him on just anticoagulation itself. So this was what treatment was started for this patient. He was started on modified Ponticelli. Now he has finished his first month, and now he is on oral cyclophosphamide. And anticoagulation, he was started on unfractionated heparin and warfarin, and now being continued on warfarin. So I'll just review some of the thrombotic complications associated with nephrotic syndrome. So this thromboembolic complications are serious complications which were known from about 1840, when the first case of renal vein thrombosis was described in association with nephrotic syndrome. But even then, there is paucity of data with regard to thromboembolic complications and their management. This is mainly because of the methodological issues involved in data collection. Most of the studies are retrospective studies with small sample sizes, and there is lack of objectivity of thromboembolic event definitions. And even there is difference with regard to the histopathological distribution of nephrotic syndrome in various populations. And depending on the imaging modalities used, and whether the imaging was done in response to some symptoms or as a screening modality, the incidence of thrombotic events has varied across various studies. So if you look at the older literature, it shows incidence of about 25% in adults and in children about 3%. Although in children the cumulative incidence is 3%, it is higher in cases of membranous nephropathy where it is 25%, and in secondary nephrotic syndrome 17.1%, and 10% in cases of congenital nephrotic syndrome. And even the onset of disease, the median time is 70.5 days, and most of the events occur within first 6 months of disease onset in adults and within first 3 months of disease onset in children. And some studies have shown that there is a second peak of thrombotic complications which occurs about 20 years after the disease onset, but this was presumed to be due to accelerated atherosclerosis associated with nephrotic state rather than nephrotic syndrome itself causing second peak. And if you look at the arterial thromboembolic complications, these nephrotic syndrome patients are at about 8 times increased risk compared to general population. And if they have any other risk factors associated with atherosclerotic disease, then their risk of arterial thromboembolism increases. So these are some of the studies which have looked into the incidence of nephrotic syndrome. If you look at the time frame of this publications from 1975 to 2008, the incidence of thromboembolic complications has varied from 20.2% to about 52%, 51.9%. But recent data has shown that this incidence has decreased, and this is a paper from 2012 which has shown that the cumulative incidence is only 3.4%, and the in membranous nephropathy it is 7.9%, and even the time to onset of first venous thromboembolic complication was 272 days as compared to 70 days in earlier publications. And even in membranous nephropathy, the median time to onset was 151 days. This might be due to improved diagnostic and treatment modalities. And coming to risk factors for thromboembolic complications, this is a univariate analysis showing the underlying disease is a significant risk factor. Either FSGS or membranous nephropathy increases the risk compared to IgA nephropathy. Even though proteinuria was a risk factor on univariate analysis, when it came to multivariate analysis, proteinuria did not contribute significantly to the risk of thromboembolic complications. It is the hypoalbuminemia rather that has contributed significantly to the thromboembolic complications. And other than that, male patients are at increased risk. So this is one study which has shown, which has compared serum albumin levels less than 2.8 or more than or equal to 2.8. If you look at the odds ratio is about 3.9. That is, they are at around 4 times increased risk of thromboembolic complications. And with regard to the type of glomerulonephritis as compared to IgA nephropathy, both FSGS and membranous nephropathy increases the risk of thromboembolic complications. And out of these two, membranous nephropathy has the highest risk. Coming to renal vein thrombosis in particular, this refers to presence of thrombus either in the major renal veins or its tributaries. This, like I said earlier, it was first described in 1840 by Rayer. This is more common in males, and there is no racial predilection. And most of the cases of renal vein thrombosis are bilateral. And when it occurs unilaterally, it is more common on the left side compared to right side. And coming to outcomes of renal vein thrombosis, the outcomes range from either spontaneous resolution to patient may develop chronic hypertension, and some patients may develop renal failure and may require maintenance dialysis. So this is again specifically looking at renal vein thrombosis. Membranous nephropathy is associated with the higher incidence of renal vein thrombosis compared to other MPGN, MCD, and FSGS, and the incidence is around 24% in this series. And coming to clinical features of renal vein thrombosis, classically what is described is the triad of flank pain, gross hematuria, and worsening kidney function. But this tends to occur only in minority of patients, and most of the patients with nephrotic syndrome will present with chronic asymptomatic renal vein thrombosis, which may be detected only on evaluation of pulmonary embolism, or if the patient has unexplained worsening of proteinuria. And there is one more thing to add to this. Patients with renal vein thrombosis per se without any glomerular disease can present with proteinuria, which can be up to nephrotic range also. And acute presentation of renal vein thrombosis is usually seen only in neonates and infants with severe dehydration, where they present with nausea, vomiting, flank pain, gross hematuria, and palpably enlarged kidneys. Some of them may develop kidney failure, thrombocytopenia, and anemia. But this presentation is not common in a case of adult patient with nephrotic syndrome, and it is usually chronic asymptomatic renal vein thrombosis. So this is detected only on imaging, and the imaging signs will depend on the speed of onset of thrombosis and degree of occlusion of the renal vein. If it is rapid onset complete occlusion, there is increase in the size of the kidney and it reaches a maximum size within 1 week, and then there is gradual reduction in size over the next few weeks. And almost 90% of the acute renal vein thrombosis will have increase in the kidney size with hyperechogenicity on ultrasound compared to other kidney if it is unilateral. And color Doppler can only detect thrombus in main renal vein and renal artery, but segmental vessel thrombosis cannot be detected with the color Doppler. So CT angiography remains the imaging modality of choice, where we can directly visualize the renal veins, where we can see the filling defects. There are other indirect signs similar to what is seen in ultrasound. And coming to sensitivity and specificity, it is about 100% with CT angiography. The other option for CT in cases of renal vein thrombosis is MR angiography, but the specificity of MR angiography is lesser compared to CT angiography. So, coming to pathophysiology of this thromboembolic events in nephrotic syndrome, we mainly look at it from three perspectives. One, genetic predisposition, then environmental risk factors and acquired risk factors. Genetic predisposition can be congenital antithrombin deficiency or factor V Leiden mutation, and environmental risk factors are common like in other cases where there is risk of deep vein thrombosis. The acquired risk factors are specific to nephrotic syndrome, and the proteinuria associated with the nephrotic syndrome tilts the hemostatic balance, and basically this hemostatic balance is dependent on the rate of excretion of these proteins in the urine and the rate of synthesis of proteins by the liver. So if you look at the hemostatic balance in nephrotic syndrome, this spectrum, this hemostatic balance, we look at it from various systems: procoagulant system, anticoagulant, profibrinolytic, and antifibrinolytic. In nephrotic syndrome, there is loss of low molecular weight proteins in the urine. So, factor 2, factor 7, factor 9, and factor 10 are consistently low. And even though factor 11, the molecular weight is 160 kilodaltons, it is usually low in nephrotic syndrome. And the high molecular weight procoagulant factors like fibrinogen, factor 5, and factor 8 are consistently elevated in nephrotic patients. And with regard to anticoagulant system, there is decrease in antithrombin and protein S. Protein C levels, although total levels may increase, free protein C levels are usually either normal or on the lower side. And with regard to profibrinolytic, there is decrease in the plasminogen and decrease in tissue plasminogen activator. And antifibrinolytic, there is increase in plasminogen activator inhibitor, and there is increase in alpha-2 microglobulin. Added to that, there is increase in RBC aggregation. This might be related to hypoalbuminemia and hyperlipidemia. And there are some differences in clot structure also. All these factors tilt the balance in favor of prothrombotic state, and this is how proteinuria contributes to urinary loss of cyanogens and cofactors and coagulation inhibitors. Hypercholesterolemia contributes to platelet aggregability, and hypoalbuminemia, it contributes to platelet aggregability and increased hepatic synthesis of factors 5, 8, and fibrinogen. And there is intravascular volume depletion associated with hypoalbuminemia, which increases the blood viscosity and hemoconcentration, which is further worsened by the diuretics which we use to treat the edema in nephrotic state. And further addition of steroids to treat the nephrotic syndrome, all these contribute to the hypercoagulability in a case of nephrotic syndrome, and thereby patient develops thromboembolic events. So, coming to prevention and management of this thromboembolic complication, prophylactic full dose anticoagulation should be considered in all patients who are at high risk for these events. And if patient already develops some thromboembolic complication, then patient should receive full dose of anticoagulation for 6 to 12 months, or the duration for which the patient remains in nephrotic state. So, these are some of the risk factors which were documented in the guidelines. Serum albumin of less than 2 or 2.5, depending on the method used. Along with that, proteinuria of more than 10, BMI of more than 35, genetic predisposition, heart failure, recent orthopedic or abdominal surgery, or prolonged immobilization. Basically, these are, other than proteinuria, other risk factors are common to general public. So, and we also assess the risk of bleeding in the patient, and if there are any significant risk factors for bleeding tendencies, then we might withhold anticoagulation. So this is the algorithm showing decision tree. If patient is having serum albumin of less than 2 or 2.5, then patient is at high risk for venous thromboembolic events, and then we assess the bleeding risk of the patient. If the bleeding risk is low, we start the patient on anticoagulation with heparin and warfarin. And if patient has high bleeding risk, then we start the patient on aspirin. If the patient's serum albumin is more than 3, then a patient does not require a prophylactic anticoagulation. If it is between 2 and 3, then we'll estimate the arterial thromboembolic event risk based on the Framingham risk criteria. If it is more than 20 per 1,000 patient years, then patient should be started on aspirin. So this is tool to identify the bleeding risk of the patient. This can be done online. This is the link to that tool. So When we have decided to start some patient on anticoagulation, then we should look at the options available for this patient also. This is a systemic review of warfarin and heparin in the prophylaxis and treatment of thromboembolism. If you look at this, most of these studies are either retrospective cohort studies or prospective pilot studies or case reports. So based on these studies, warfarin and low molecular weight heparin were effective in treating thromboembolism, and like if you look at this second study, even it was effective in the prophylaxis against thromboembolic events. So based on these results, again, KDIGO has recommended intravenous heparin followed by bridging to warfarin. One thing to be noted is heparin binds to antithrombin and exerts its anticoagulant effect.
Dr. Naveen,
Sir.
gentle reminder, you're exceeding your time. Please come.
Yes, sir, I'll finish in 2 minutes. Because there is deficiency of antithrombin, there is resistance to action of heparin in nephrotic syndrome patients, and they might require higher doses of heparin because of heparin resistance. Or the other way to overcome heparin resistance is to supplement the patient with antithrombin. That can be done through FFP transfusion, and then the patient should be bridged to warfarin, and the INR target is 2 to 3. And coming to DOACs in the treatment of thromboembolic complications in nephrotic syndrome, here also, like we can see, most of them are case reports and only one randomized controlled trial, and most of them have shown either poor response or failure of treatment with the new onset of thrombotic complications while the patient was on DOACs. This might be because of warfarin, we have a definitive 2 INR to monitor the anticoagulant efficacy and adjust the dose. But for DOAC, factor 10A activity is not routinely monitored, and we usually do not we start the patient on fixed dose of DOACs. So that might be one reason, and further studies are required before we can either recommend DOACs for the treatment of thromboembolic complications. So with this, I conclude, and these are 2 similar cases which have been reported earlier in literature. This was from Cleveland Clinic Journal, showing bilateral renal vein thrombosis in a nephrotic syndrome patient with pulmonary embolism. The patient was treated with rituximab, and the patient did well with rituximab. And this was a case report from Hyderabad itself, by Dr. Praveen. This was showing bilateral renal vein thrombosis. Unfortunately, this patient did not undergo full evaluation and treatment, and he has left against medical advice, and he had succumbed. To conclude, thromboembolic events are potentially fatal complications of nephrotic syndrome. The risk is highest in cases of membranous nephropathy and in patients with severe hypoalbuminemia and other associated risk factors. Prophylactic anticoagulation should be considered in high-risk cases after due consideration of the bleeding risk. And the drugs of choice are heparin and warfarin. High degree of suspicion is needed for early diagnosis and prompt treatment of potentially life-threatening complications, which usually present with very minor symptoms like either increase in proteinuria or worsening of creatinine. With this, I thank the seniors for giving me this opportunity. Thank you.
Thank you, Naveen. It was a good presentation. So, good evening, Sri Bhushan.
Hi, good evening.
Any comments from your side?
Uh, uh, yes. Membranous nephropathy is very well known to be associated with the thrombotic complications anywhere in the body. And probably we have seen almost complication every nook and corner of the human body, to the brain, to the toe. And not only primary, even the secondary involving like lupus nephritis, and these patients also will get into complications. I have not seen any bilateral renal vein thrombosis.
Sorry, sir, I am not able to hear.
My voice is not audible?
You're audible, sir.
Yeah, you're audible, sir. You're audible, actually.
Yes. So, but a single unilateral renal vein thrombosis and other complications involving including the IVC, SVC, and the subclavians, popliteal, cardiac, and brain, everywhere the thrombosis, both arterial as well as the venous, we happen to see. And it's very, very common with membranous. We have seen with other things also. But evaluation is not so easy. Many times we don't even find any underlying etiology. You can do protein C, protein S, antithrombin 3. You can do factor 2 and factor 5 assay. But very few cases only we find an etiology underlying, whether associated feature along with that. It's a nephrotic syndrome per se or of membranous nephropathy, why it is specifically associated with that. As far as the renal vein thrombosis of membranous is concerned, many people also felt that it is the renal vein thrombosis that led to membranous nephropathy rather than membranous nephropathy that led to renal vein thrombosis. So these are the things which we were discussing before. And the characteristic features of this particular renal vein thrombosis also can be seen in the histopathologically when we do a biopsy, where even if you don't make out clinically, radiologically by other means also, you can make out in the histopathology by certain characteristic features where you can have a suspicion of renal vein thrombosis when the patient had. So very interesting. And if you find out very early with high index of suspicion, you can treat it effectively, and the patient will get benefited also because of that. So early high index of suspicion in every membranous nephropathy is very, very important. Nowadays, we have been getting a lot of referrals from vascular surgery and other where arterial and the venous thrombosis which they are making out, and they are finding it's some proteinuria, they are referring to us. And we are doing biopsy to find that it's membranous nephropathy. Recently, we had one patient where the entire venous system of the body, the human body, entire body, venous system from top to toe is actually thrombosed. Ultimately, we started the treatment, but she improved, and she's coming for the follow-up also regularly. Then after a few weeks, then we have done a biopsy carefully, and we found that it's membranous nephropathy once she became okay. So every student and a resident who has been managing nephrotic syndromes and otherwise also, they should be suspecting about thrombotic complications which are associated with nephrotic syndrome per se, more so with membranous nephropathy. And very interesting and very nice presentation, though very exhaustive and very nice presentation actually.
Thank you.
Thank you.
Thank you, sir. We have a few quick questions from Dr. Abdul.
For Dr. Navi. So
Yeah.
Dr. Hamidi asks, how long should we give rituximab in membranous nephropathy?
There are different protocols, different studies have been used different protocols. Like what we regularly follow here is 375 milligrams per meter square at day 0 and 2 weeks, and then subsequently we measure the CD20 levels and decide. And if there is worsening of proteinuria, we might consider monitoring PLA2 or antibody levels in PLA2 or antibody positive cases.
Yeah, and there's a few more questions. How to suspect rituximab antibodies, which leads to the failure of the treatment, and how to manage?
Like one thing I can think of is CD20 monitoring the CD20 level, CD19 levels, and if a patient is not responding in spite of repeated doses of rituximab, then probably we should consider measuring anti-rituximab antibody levels in that patient.
Yeah, the treatment part, we can even think of newer drugs like ofatumumab and cyclophosphamide also being given in these kind of cases where they don't respond to rituximab or they have antibodies. Yeah. Usually the antibodies are not seen earlier. Before 6 months, it is not so common, but after 6 months, it is common to see rituximab and antibodies to rituximab, and it is really very difficult to measure the antibodies as well. And if the patient is not responding, there is a proteinuria despite giving your doses, then I think probably we should suspect antibodies to rituximab. So if we have further, if we have no more questions, we'll move to the next session.
Before that, we thank Dr. Venkatamana sir and Dr.
Thank you.
Srivishwanath sir for chairing the session.
So
Thank you,
moving on
Dr.
to
Naveen. Thank you, Dr. Naveen, for presentation. Madam, please.
Yeah, moving on to the next interesting session, we have Dr. Chetan, who is a senior resident from Usmania. He's going to present a case on CKD in young. We request our chairpersons, Dr. Urmila Anand Madam, who is a senior consultant nephrologist at Yashoda Hospital, and Dr. Rashekar Chakravarti sir, who is a senior consultant nephrologist at Star Hospitals, to chair the session. Over to you, sir.
Good evening. Welcome again, everybody, to this session. Both Dr. Urmila and me are very happy to see Dr. Chetan discuss this important topic. CKD in young, at least in our country, is a very important topic to know. You may all be aware about SEEK study putting the prevalence of CKD at 17% in our country. We had done some work in urban slums of Hyderabad since 2015, and we found, and this was published in World Congress of Nephrology Proceedings, 14.7%. So that's a huge burden on our community as far as CKD. And unfortunately, in our country, young CKD is quite common. When I say young, I don't mean children, but it is common. And there is data to support that hypertension and urinary abnormalities, even in children, are quite common. So with this background, let us go on to hear what Dr. Chetan has to tell us. Dr. Chetan, please.
Good evening, my chairs, respected teachers and senior faculty. My topic is rare case of CKD in young. Coming to the case, he's a 19-year-old boy, native of Anantapur, presented for the evaluation of renal transplant to Usmania General Hospital. Coming to the history of presenting illness, at the age of 8 years, way back in 2011, he had a fever, loin pain and vomitings, and he was taken to a nearby hospital and informed to have bilateral renal calculi with urinary tract infection and treated with antibiotics and right side double J stenting. And after a couple of months, he improved, symptoms were relieved and stents were removed. Then he was asymptomatic till age of 14. In February 2017, he developed similar complaints and he was taken to a tertiary care hospital where left PCNL was inserted and was removed after 3 weeks. And from 2017 to 2021, he had a history of nocturia. This history was given on repeated probing and he was never taken to a hospital. But around the age of 18 in May 2021, he had decreased urine output, bilateral loin pain and facial puffiness, which alarmed the parents, and he was taken to a district hospital where he was where parents were informed to have he was having bilateral multiple renal calculi with renal impairment and shrunken kidneys. He was treated with hemodialysis, ureteroscopic lithotripsy, along with bilateral DJ stenting was done. And his renal function didn't improve. And in June 2021, he was initiated on maintenance hemodialysis, and bilateral DJ stents were removed in October 2021. Coming to the personal history, he takes mixed diet, bowel bladders are normal, non-alcoholic and non-smoker. Family history, no significant family history of stone disease in both maternal and paternal families. Antenatal and postnatal history are insignificant, born out of non-consanguineous marriage, first in order, term vaginal delivery. Medication history, right now he's on antihypertensive, sodium bicarbonate supplementation, weekly thrice maintenance hemodialysis with erythropoietin and iron sucrose injections. Coming to the examination of the patient, general examination is conscious, coherent, height is 155 centimeters, weight 36 kg and BMI is around 15, pulse 96 and BP 170/90 mmHg. Right RCF is there with good 3. Bedside fundus examination is normal and there are no retinal deposits. Coming to the systemic examination, cardiovascular nervous system examinations are normal. Skeletal survey, there are non-tender swelling noted in both elbows of the patient. With this history and examination, the provisional diagnosis CKD stage 5D on maintenance hemodialysis, vintage of 9 months, access right radiocephalic fistula, probably chronic interstitial nephritis, and renal stone disease. We suspected primary hyperoxaluria considering his age of first presentation of symptoms and the progression. Going through the reports, we could trace only few reports of the patient. On the right side, we can see the X-ray showing a left-sided renal calculi, and on the left side we can see the CT done in October 2021, which shows in situ bilateral degestions with cortical nephrocalcinosis on the both sides. With that, we have proceeded with the clinical exome sequencing for to detect primary hyperoxaluria, mainly AGXT mutation, which turns out to be homozygous positive, and which is likely pathogenic. Coming to the topic proper, hyperoxaluria. Hyperoxaluria results from either inherited disorders of glyoxylate metabolism leading to hepatic oxalate overproduction, or might be due to increased intestinal oxalate absorption. And the prevalence is 1 in 58,000. Coming to the cause of hyperoxaluria, it could be primary, which are type 1, type 2, type 3, or it could be secondary, mainly of enteric hyperoxaluria due to increased intestinal oxalate absorption in small bowel diseases like Crohn's, celiac, jejunal bypass, pancreatic failure, orlistat, somatostatin analogs. Or it could be due to pyridoxine deficiency, or it could be due to excessive intake in form of star fruit intake, ascorbic acid intake, glycine irrigation, ethylene glycol consumption, or methoxyfluorine ingestion. Coming to the oxalate metabolism, majority is in liver, which accounts for 60 to 80%, and from dietary sources, it's only 5 to 15%. Average daily oxalate intake is approximately 80 to 130 milligrams, but majority is eliminated from the gut in stools, and some part is degraded even by the intestinal bacteria such as Oxalobacter formigens. Coming to the metabolism in the liver, which it happens at 3 levels: mitochondria, peroxisome, and cytosol. In mitochondria, the hydroxyproline, which is a component of collagen, is converted to glycolate with the help of hydroxyoxyglutarate aldolase and glyoxylate reductase, hydroxypyruvate reductase. This glycolate moves into the peroxisome, where glycolate is converted to glyoxylate with the help of glycolate oxidase, and this glyoxylate, some part is converted into oxalate with the help of glycolate oxidase, or majority of the part undergoes series of reactions with the help of alanine glyoxylate aminotransferase. In cytosol, the glyoxylase is converted to oxalate with the help of lactate dehydrogenase, and this oxalate is eliminated by the kidney. In intestine, mainly oxalate absorption happens through paracellular and transcellular transport. SLC26A6 and SLC26A3 are the two transporters which help in the intestinal absorption. In kidney, plasma oxalate doesn't have any known function in the human body, and it is rapidly excreted by the kidney via both glomerular filtration and tubular secretion. The transporters helpful are SLC26A6 in proximal tubule and SLC26A1. Coming to the primary hyperoxaluria are inborn errors in metabolism of glyoxylate and oxalate. These are rare autosomal recessive disorders, first described by Lepotcher in 1925. Primary type 1 is the most common form. Prevalence is around 1 to 3 cases per million population, and incidence is 1 case per 120 live births per year. 1 to 2% cases of the pediatric end-stage renal disease are primary hyperoxaluria in Europe, US, and Japan. But this prevalence is more in countries with consanguineous marriages like North African and Middle Eastern nations. It might be up to 10% of the prevalence. Coming to the presentation, primary hyperoxaluria type 1, it is the most common for which accounts for 80% of the cases, and it is the most severe form of disease. Nearly all patients progress to ESRD. Mutations are seen in gene encoding alanine glycolate aminotransferase enzyme, which is located on the chromosome 2p. Median age of presentation is 4 to 7 years, but it is variable, can present even till 6th decade. Infantile form is the most dangerous form. 80% of the cases rapidly progress to ESRD by 3 years. Childhood and adolescent form, they can present with recurrent urolithiasis and progressive renal failure. Late onset form, it's generally they present with occasional stone passage, sometimes ESRD as a first presentation itself. Coming to the primary hyperoxaluria type 2, it's second most common, less severe form compared to primary type 1, and mutations are seen in gene encoding glycolate reductase and hydroxypyruvate reductase enzyme, which is located on the chromosome 9q, typically presents in the childhood. Type 3 is the least common form, less severe than type 1 and type 2. Mutations in gene encoding Hoger gene, and early symptomatic presentation is in first months of life. Coming to the clinical features, there is a wide variation in clinical presentation ranging from severe infantile nephrocalcinosis with failure to thrive to just occasional stone formation. 20 to 50% have advanced CKD or even ESRD at the time of diagnosis. The major sites of crystal depositions are kidney, blood vessels, and bone, and it can also affect large joints, retina, skin, bone marrow, heart, and CNS. Coming to the kidney involvement, it can be just a renal stone disease, or it could be tubular interstitial injury and fibrosis. They can present as an acute kidney injury or even in end stage. Coming to the pathogens of renal damage in hyperoxaluria, it's like other crystal depositions like uric acid and even monoclonal light chain deposition, where it will they'll activate the NLRP3 inflammasome and it triggers interleukin 1 beta induced inflammation. These are biopsy, renal biopsy of primary hyperoxaluria patients, where we can see rhomboidal or bipyramidal crystal deposition in the tubules, and on polarized light, they are birefringent. Coming to the skeletal system involvement, the bone compartment is the main site for oxalate storage. They can present with severe bone pains, pathological fractures with low trauma mechanism, stunted growth, or even erythropoietin resistant anemia. Joint involvement can be synovitis, chondrocalcinosis with oxalate deposits. X-ray characteristics are variable. They can present with dense metaphyseal bands, cystic bone changes, deformities, subperiosteal resorption, blurred trabecular patterns, radiopaque crimson flat bones, or even increased bone density in vertebra and iliac crest. This is X-ray of the patient where left elbow X-ray was taken, which is showing crystal deposition in the elbow joint. Coming to the eye involvement, generally they present with diffuse oxalate crystal depositions in the retina, which can be examined in fundus and slit lamp. Nervous system examined, they can present with movement disorders or with extrapyramidal symptoms if deposition happens in basal ganglia and surrounding structures, or if nerves are involved, they can present with ischemic neuropathy, and they can even present with myopathy if there is a deposition in the muscles. Cardiovascular, generally they present with vessel calcifications, arrhythmias, heart blocks, even systolic and diastolic dysfunction and heart failure. Coming to the skin involvement, they can present with painful skin nodules, necrosis, gangrene, calciphylaxis like skin lesions, and pruritus. Coming to the diagnosis of primary hyperoxaluria, central to evaluation is that whenever a patient presents with urolithiasis, detailed assessment of the risk of renal stone formation should be done. When a patient presents with kidney stone, medical history should be taken, including medications, family history of nephrolithiasis, and stone history for past how long he's having stones, or is it bilateral, single stone, or a multiple stones, or is it unilateral or bilateral. And we should go for a biochemistry evaluation like serum sodium, potassium, chloride, bicarbonate, creatine, calcium, uric acid, phosphorus should be done. Urine analysis should be done. And if patient brings a stone analysis should be done. But if a patient is having recurrent stores or high risk patient, like multiple or bilateral stone disease, stones in pregnancy, stones in children, non-calcium stones like cystine or uric acid, recurrent stone formation, strong family history of stones, stones in the setting of solitary kidney or an anatomical abnormality, stones in setting of renal insufficiency, or systemic diseases with increased risk of nephrolithiasis like gout, bowel disease, distal renal tubular acidosis, or if with critical occupations like airline pilots, sailors, military personnel, firemen. In those patients, we should go for a 24-hour urine collections for twice, and we should go for an analysis. In primary hyperoxaluria, more than 95% of the stones are calcium oxalate monohydrate stones, which are pale in color and non-homogeneous in ecotexture. Urine microscopy may reveal bipyramidal or rhomboidal crystals, which are birefringent and under polarized light. Generally, kidney stone formation and nephrocalcinosis starts even with preserved GFR with GFR more than 90 also. But systemic oxalosis like deposition in the other organs generally happens from CKD stage 3B. And other markers like even urinary oxalate levels are is elevated from CKD stage 1, even if in preserved GFR and even in asymptomatic patients also. But plasma oxalate levels are elevated from CKD stage 3B. Coming to the evaluation with urine oxalate levels, excretion of urine oxalate levels is variable according to age. Generally, urine oxalate levels more than 0.7 millimole per 1.73 meter square per day, or urine oxalate to creatinine ratio greater than reference range for age with suggestive clinical symptoms, and absence of secondary hyperoxaluria indicates further evaluation with genetic testing. But we can check for other glyoxylate metabolites also, like glycolate is elevated in type 1 and type 3, L-glycerate is elevated in type 2, and hydroxyoxoglycerate is elevated in type 3. Measurement of plasma oxalate level should be reserved for patients with CKD stage 3B and beyond. More than 50 micromole per liter says primary hyperoxaluria. Coming to the genetic analysis, A definitive diagnosis, genetic analysis is warranted for definitive diagnosis of primary hyperoxaluria. Since 80% of the case of primary hyperoxaluria type 1, generally we go ahead with type 1 testing for AGXT gene mutation. If it is negative, we should look for the type 2 and type 3. Disadvantage with genetic testing is not all genetic variants are pathologic. Deletions may not be detected unless parental studies are also performed. In some cases, the phenotype is typical of primary hyperoxaluria, but no mutation is detected because the mutation can lie in promoter or other regulatory sequences, or because some other yet undefined metabolic defect is present. So in these cases, we can go ahead with liver biopsy, and we can perform levels of alanine glyoxylate aminotransferase and glyoxylate reductase hydroxypyruvate reductase enzyme levels. Prenatal diagnosis can be established in first trimester of pregnancy, particularly in patients with family history of primary hyperoxaluria. Other investigations could be bone biopsy, where we can see oxalate crystal deposition surrounded by granulomatous inflammation, bone mineral density measurement, high resolution peripheral quantitative CT, where we can see decreased compartmental bone mineral density volume and disorganized trabecular microarchitecture. For eyes, we can go for a fundus and slit lamp examination. If cardiac involvement, we can go for a ECG and echocardiogram. Coming to the management of primary hyperoxaluria, coming to the supportive measures, mainly fluid intake. Fluid intake is must in excess fluid intake is must in primary hyperoxaluria management. Around 2 to 3 liter per meter square body surface area. And next, avoid oxalate diet. Generally, primary hyperoxaluria is due to endogenous production of oxalate. Avoiding oxalate-rich diet can be advised as a precaution. Calcium intake, it should be maintained normal since dietary calcium restriction results in more intestinal oxalate absorption. And oral potassium citrate around 0.1 to 0.15 milligram per kg per day to alkalize urine and inhibits crystallization, or as calcium oxalate crystallizes in acidic urine. Or if to avoid potassium load, we can give oral sodium citrate also. These are the oxalate-rich foods, which include the foods to be avoided are potatoes, raspberries, spinach, chocolate and cocoa, processed meat, even seeds and nuts, and wheat. The low oxalate foods are coffee, even lemon, water with lemon, bananas, broccoli, even peppers and papaya. These are low oxalate foods. Coming to the different treatment strategies, there are traditional management options like pyridoxine citrate compounds, dialysis, transplantation, and a substrate reduction therapy like lumasiran, nedosiran, and stiripentol. And to increase intestinal oxalate degradation, oxalobacter formatins or other forms of supplementation, and chaperone therapy, which includes pyridoxine and betaine. Even there are the new therapies which are under trials, like to target the inflammasome, mainly NLRP3 inhibitors, interleukin 1 beta receptor inhibitors, and TNF receptor inhibitors. And enzyme restoration therapy like induced pluripotent stem cell therapy or even liver cell transplant are under trials. To remove intestinal oxalate, we can give probiotics like Oxalobacter formigenes, which is FDA approved in June 2020, or we can give oxalate decarboxylase enzyme, which is typically purified from fungi and bacteria, which converts oxalate to carbon dioxide. There are multiple formulations available. Of the 3R Nephure, where this enzyme is isolated from Cyanococcus elongatus bacteria, and oxygen, which is isolated from Bacillus subtilis. Redoxicase, it is an encapsulated crystalline form of oxalate decarboxylase enzyme from Bacillus subtilis. Coming to the chaperone therapy, it uses small molecule therapeutics capable of restoring functional enzyme conformation in the liver. There are two mainly, pyridoxine hydrochloride and betaine. Both were helpful only in primary hyperoxaluria type 1 because they help in stabilizing only alanine glyoxylate aminotransferase enzyme. Generally, pyridoxine hydrochloride initiating dose is 5 mg per kg per day and should not exceed 20 mg per kg per day. Trial period should be 3 months. We call patient as a responsive if there is more than 30% decline in urine oxalate levels from the point of treatment initiation. If no response after 3 months, we should discontinue supplementation. Coming to the betaine, even it also helpful only in primary hyperoxaluria type 1. Coming to the RNA interference-based therapies, there are three mainly: lumasiran, nedosiran, and stiripentol. Coming to the lumasiran, it blocks glycolate oxidase and reduces the oxidation of glycolate to glyoxylate. It is a 3 monthly subcutaneous injections around 0.3 to 6 mg per kg. approved in European Union and US in November 2020. The drawbacks are repeated injections, injection site reactions, and abdominal pain. These are visual abstract in CJASN showing the phase 1 and 2 trials of lumasiran, and they have concluded that lumasiran had an acceptable safety profile and reduced urinary oxalate excretion in all patients with primary hyperoxaluria type 1 to near normal levels. Coming to the trials of lumasiran, mainly Illuminate A, B, and C trial. All 3 trials are undergoing. In Illuminate A, main inclusion criteria is age of 6 or more with preserved EGFR, and the preliminary results were 65.4% reduction of 24-hour urine oxalate levels at month 6, and there were no serious adverse effects were reported. Estimated completed date is May 2024. They have proceeded to Illuminate B because they have included the children also of age less 5 or less. Even these results are awaited. And Illuminate C is main inclusion criteria of all ages, even with reduced EGFR and even on chronic hemodialysis patients. Coming to the nedosiran, it blocks lactate dehydrogenase, thereby decreases the conversion of glyoxylate to oxalate. Even this is a visual abstract in ISN, International Society of Nephrology, where they have concluded that single-dose nedosiran demonstrated acceptable safety and evidence of pharmacodynamic effect in type 1 and type 2 primary hyperoxaluria. Even a trial of nedosiran is also undergoing, where they have included more than 6 years of age with preserved EGFR. Even preliminary results were not out. Coming to the stiripentol, it is a LDH type 5 inhibitor which decreases glyoxylate to oxalate conversion. The phase 2 clinical trial is ongoing. This is a table published in Kidney International Reports 2020. If RNA interference therapy is available, we can initiate RNA interference therapy irrespective of the EGFR, even in preserved EGFR, preserved glomerular function, or even in chronic hemodialysis patients, and we can follow up the kidney function. And we should assess the systemic oxalate levels, plasma oxalate levels. If plasma oxalate levels drops to near low value, we can go ahead with earlier kidney transplant. But if they are persisting, we should continue the RNA interference therapy. Coming to the gene therapy, different gene therapies were tried, like induced pluripotent stem cells, which could further differentiate into hepatocyte-like cells that displayed low residual alanine glyoxylate aminotransferase expression. And we can, they are trying normal AGXT gene delivery through viral vectors, mainly adeno-associated virus 5 and 8 were used. And IV administration of SVAC. It's developed from vector-derived. It is a vector derived from macaque polyoma SV40 virus. Results are good in mice and non-human primates, but human trials were not yet done. Urological intervention in primary hyperoxaluria. Ureteroscopic laser lithotripsy with percutaneous store removal are preferred to USWL. Because extracorporeal shock wave lithotripsy is not recommended because calcium oxalate stones are hard to break and it results in high parenchymal damage. In patients with repeated renal colic, double J stenting can be performed for pain control and prevent further renal damage. Bilateral nephrectomy may be proposed in patients on renal replacement therapy to minimize risk of infections, obstruction, and stone passage. Coming to the renal replacement therapy, conventional hemodialysis and even peritoneal dialysis do not sufficiently eliminate oxalate levels. Generally, oxalate is produced around 4 to 7 millimole per body surface area per day, but with each session we can remove only 2 to 3 millimoles of oxalate is removed for each session of conventional hemodialysis. Even weekly thrice can remove only up to 6 to 9 millimoles, which is equivalent to just 2 to 3 days of the endogenous oxalate production. So other feasible strategies could be preemptive transplantation, short daily sessions of high flux dialysis, nocturnal dialysis, or conventional hemodialysis with nocturnal peritoneal dialysis. Coming to the transplantation, ideally organ transplantation should be planned prior to the onset of ESRD and systemic oxalosis, that is prior to CKD stage 3B. And there are 4 different types of, there are 4 different modalities of transplant in primary hyperoxaluria, where isolated liver, isolated kidney, liver followed by kidney, or combined simultaneous liver kidney can be tried. With preserved EGFR more than 40, isolated liver transplant could be an option. But if EGFR is less than 40, we should combine simultaneous liver kidney transplant as a treatment of choice, followed by liver, followed by kidney. We should not do isolated kidney transplant. A combined liver kidney transplant, the benefits of doing this is the recipient has a single exposure to the risk of anesthesia, and immunological benefits include exposure to just one set of antigens and protection from both acute cellular and antibody mediated rejection for the kidney allograft. These are research article published in BMC Gastroenterology in 2020, where they have studied two groups, sequential liver kidney versus combined liver kidney, and they have concluded that sequential liver kidney seems to be an alternative option with strict condition for combined liver kidney transplant, since patient survival was not significantly different between the both. These are systemic review published in Pediatric Nephrology Journal 2021, where they have studied 51 observation studies from 1975 to 2020, which covering 756 combined liver kidney transplants, 405 kidney transplant alone, 89 sequential liver kidney transplants, and 51 preemptive liver transplants. And they have concluded that combined liver kidney transplant leads to a superior kidney graft survival compared to kidney transplant alone. And however, evidence for merits of sequential liver kidney transplant or just kidney transplant in pyridoxine hydrochloride responsive patients was scarce. These are articles published in Liver Transplantation Journal 2020, where long-term results of combined liver kidney transplantation for primary hyperoxaluria type 1 from France. They have included 54 patients with primary hyperoxaluria from 10 different centers from 1979 to 2010. And they have concluded that.
So, Dr. Chetan, sorry to interrupt. Can you please conclude?
Yes. Coming to the post-transplantation reversal, after combined liver kidney transplant, urinary glycolate levels immediately normalizes, plasma followed by plasma oxalate levels, but urinary oxalate levels remains higher for elevated for longer time due to slow solubilization of systemic calcium oxalate deposition. So recurrent nephrocalcinosis can happen. So protection strategies should be continued even after transplantation, like high fluid intake, crystallization inhibitors, and daily high efficiency post-transplant dialysis. Can we predict or prevent oxalate deposition in the allograft? Yes, we can assess. We can do by periodic assessment with ultrasound of kidneys, extensive skin examination, neurological examination, monitoring of eyes with fundoscopy, assessment of cardiac involvement, bone involvement. That's it. Thank you.
Dr. Chetan, thank you very much. If you could kindly unshare your screen, I think. And I don't think there are many questions, except there's a question in the chat box asking, is peritoneal dialysis effective in primary hyperoxaluria?
No, ma'am. Both conventional hemodialysis and peritoneal dialysis removes oxalate levels less than the rate of production per day. So a conventional hemodialysis with nocturnal peritoneal dialysis could be a feasible strategy rather than peritoneal dialysis alone or hemodialysis alone.
Have you ever heard of something called Scheinman scoring and how it helps you to differentiate between primary and secondary hyperoxaluria? Nowadays, you have genetic testing. Earlier days, we could do something called Scheinman scoring in a biopsy. And there are studies from India to show a cutoff value which helps you with a diagnosis of primary hyperoxaluria.
Sorry, ma'am, I don't have idea regarding this.
This is a very simple test of looking at a biopsy in 10 fields, 10 non-overlap. I think if Dr. K.V. Dakshinamurthy is there, he would have noted. We used to do it in Vellore, and you can find out in tubules how much of oxalate is deposited, and you get a score. Now, the study from India, from Vellore, had shown a very high difference between the two. Given a choice, which will you do now with your, let's say, current expertise? A combined liver kidney, sequential, or isolated liver at different levels of GFR? Or let's say at a GFR less than 20, what would you like to do?
The best option would be combined liver kidney transplant, but we are discussing with surgical gastro team, and we are trying to enroll him in Jivandan program so that he may get the liver and kidney from the same cadaver.
how does it matter? Because the liver itself protects you from the antigenic exposure, no?
But already
A single antigen exposure. So rejections are much lesser if you have a liver transplant in a patient.
yes,
So do you need from both, or what is the problem we have with Swanlata is the Jivandan? Why can't we have a sequential liver? So you only told us, no, that the oxalate removal with conventional hemodialysis is very ineffective.
Very ineffective.
So when you do a combined liver kidney, your oxalate excretion does not normalize within 1 day, it still continues.
Now, ideally, it would be a sequential. First, you should go for a liver transplant, subsequently go for a kidney transplant.
At least in end-stage kidney patients. That's all. Anybody else? Ashika, you would like to? Madam Dr. Anuradha, maybe?
Yeah. Good evening, everyone. And that was a very interesting case. Dr. Chet, we have seen a lot of medullary nephrocalcinosis in patients with primary hyperoxaluria, but in your case, I think it was completely only cortical.
Yes,
There was no medullary. Although cortical calcification also can occur in primary hyperoxaluria, but more often we have seen, I mean, it is classic teaching that one of the causes for medullary nephrocalcinosis is primary hyperoxaluria. Then my question is, you have elaborated on so many treatment modalities to, to bring down the oxalate load and so many new drugs. Are any of them available for commercial use?
RNA interference therapies are not available. For my knowledge, they are not available in India, ma'am. But
in India, what about, I mean, of course, there are a lot of trials going on, but I'm asking for commercial use.
No, ma'am, for my knowledge.
Okay. So everything is at a theoretical level. I mean, practically, we are still doing what we used to do. Isn't it?
Yes.
I also agree with Urmila that it should be a sequential. First, we have to do a liver transplant if possible, and then follow it up with a renal transplant.
Oh. Rachika, anything? Any comments from your side?
I just wanted to share the youngest one we had was a 1.5-year-old child. After a episode of diarrhea, went on dialysis, we had put on PD. So you can manage hyperoxaluria both on HD and PD. Of course, experience is quite small. You have to do more aggressive dialysis. And even post-transplant, sometimes if you have done an inadvertently transplant in hyperoxaluria. I think Vellore has a series on post-transplant hyperoxaluria post-transplant. Daily dialysis, then hydration. There is a protocol for it, published from Vellore, if I remember right.
Yes, when we were students, we used to do daily dialysis, pyridoxine, magnesium, and take the patients for transplant. I think during my training, we had almost 5 or 6 of them. The results were not very
great. But first 1 week, and you may have to dialyze even pre-transplant.
No, before dialysis, we used to dialyze every day for 7 to 10 days. And then again, we didn't have all these measurements, urinary, and I think now nobody will do this. With the availability of liver transplant, we used to give high dose pyridoxine to our patients, very high dose pyridoxine.
Yes, sir. Dr. Soundarajan, sir. Please.
Permit me to quote our publication in the Indian Journal of Nephrology in, I think it's something around 97 or so, about the 2 case reports of isolated kidney transplant, because I'm talking about 15 years back when we didn't have access to liver transplant. I think we have done 1 or 2 cases of isolated kidney transplant and followed them up. And I think one lived for 6 years, another lived for 8 years. We lost the graft. I think intense dialysis followed by transplant was the only option available. And I'm very happy Madam Urmila recalled the CMC publication about the Siemens scoring about the biopsy. That was the only way you used to confirm oxalosis those days, about doing an fructose biopsy when the biochemistry genetic studies were limited. Okay, this is probably centers where I still don't have access to liver transplant. Still, it could be a possibility. Thank you.
So I think if there is no more cases or discussion, I thank you all, and I sort of ask the moderators to close the.
Thank you, chairpersons, and thank you, Chetan, for the wonderful session. And we now request Dr. Anuradha Raman ma'am, who's a senior consultant nephrologist at Sunshine Hospital, and Dr. Manisha Sahai madam, Professor HOD, Usmania General Hospital, to give her conclusion remarks.
Good evening, everyone. As usual, I think we had 3 very interesting cases. First on TMA, yes. Now, with the availability of genetic studies, we are able to diagnose more and more of TTPs or much early, and then treat. Of course, eculizumab is not available, but nevertheless, we are at least able to make a diagnosis. The availability of ADAMTS13, which is also, we are getting, it has made at least our diagnostic efficacy very good. So that was a very detailed discussion on thrombotic microangiopathy. Membranous nephropathy, yes, it's not at all unusual. We have so many patients with especially membranous nephropathy, who present with renal vein thrombosis. And of course, the last was primary hyperoxaluria, which again, we know that any stone disease, especially before we take them on to a transplant, we need to rule out hyperoxaluria, because in the absence of a combined liver and kidney transplant, which when we did our training, which was just a liver transplant, was not even, it was unthinkable. Then we had to rule out a primary oxaluria because the recurrence was so high immediate post-transplant. So thank you, presenters, for that wonderful session. It's always a learning curve, and every session, every case, however common it is, gives us 1 or 2 new points to learn. So I thank the Hyderabad Nephrology Forum, Dr. Swarna, to have given me this opportunity to give my concluding remarks. Over to you.
Thank you, madam. Thank you, madam. Now, vote of thanks by Dr. Deepti. Dr. Deepti?
Yeah, Dr. Manisha is not there. Dr. Manisha?
Dr. Manisha is traveling.
Okay.
So she told me that if her flight was delayed, so she was not able to. But if the flight is further delayed, she said from the airport she could still join. But probably she had to leave, because I saw her for some time. In the first discussion, we saw her, but I think she had to leave.
Yeah, Dr. You can go ahead with the vote of thanks.
Good evening, everyone. Today's academic session gone through very interestingly and was with good new points. This would not be possible without the active participation of our speakers, Dr. Pranitram, Dr. Naveen Kumar, and Dr. Chetan. And I would like to thank all the speakers, and I would like to thank all the chairperson, Dr. Soundararajan sir, Dr. K.V. Dakshinamurthy sir, Dr. Venkatramana sir, Dr. Bhushan Raju sir, Dr. Ashekar sir, and Dr. Urmila madam. And I extend my thanks to all the moderators, Dr. Anuradha and Dr. Vikram Kumar, and especially our audience, and hoping to conduct more academic activities in the coming months. Let's conclude this session. Thank you for giving me this opportunity. Thank you.
Once again, thank everyone for the wonderful session. I think it was a very great discussion. Everybody has enjoyed it. I personally have enjoyed it very well. And if there are no more comments, let us conclude and let us meet for the next session, the nephrology session in the month of June. Thank you. And I would like to request all of you to please send your suggestions, your remarks, or whatever your ideas are there, so that we can improvise our nephrology forum. Thank you. Thank you very much.
Wish you all a happy weekend. And good night.
Good night. Good night.